Let me first of all say how much fun this has been, and this is the session I think that's going to address some of the questions that I've been hearing in our dialogues in the hallways and around the water cooler, so to speak. And that is, how do you translate some of the things that you've heard into creating a bed-med culture at your institution? And we're happy to share and have shared some of the things that we learned along the way. And we've assembled a panel of folks who represent various viewpoints and people we've gotten to know because they've been doing some of these things. So let me start first. On my left is Brian Garibaldi. Brian's from Johns Hopkins, where he's an assistant professor. And we know from some of his correspondence with us, especially with Errol, my colleague, that they've been doing exciting things at Hopkins that we'd love to hear about. Next to him is Stephen Russell. Stephen is also an assistant professor of medicine at the University of Alabama. We were very fortunate that Stephen came out here and spent a day with us, visiting with us, with a charge from his chair, as I understand it, to develop something that improved clinical skills, or that did the sort of things that we were trying to do. And next to him is our friend and colleague Andy Elder, who needs no introduction at this point. And then I'm very pleased to introduce my colleague Maya Artandi. Maya is a beloved member of our outpatient faculty, clinical assistant professor here, and has really become an esteemed member of our group, working very hard to take our modules, which tend to be very much inpatient focused. Even the very word bedside is an implication that it's all inpatient, and bring it to the outpatient world, because really that's where the future lies in terms of people spending more and more time there. And last but not least, Steve McGee, who again you know well from yesterday. So maybe we should just have each panelist talk a little bit about creating a bed-med culture at your institution. And start with you, Brian.
Well, thank you so much for the invitation to be part of this panel. It's a great privilege to share what we've been doing the last couple of years at Hopkins. So I did my internal medicine training and med school training on the Ulster Medical Service, and somewhere along that line in the last 15 years, I think we all signed a contract that says you have to start any speak or any talk with either a quote by Osler or end with a quote by Osler. So John actually stole my favorite one yesterday about medicine is learned at the bedside, not in the classroom. But there's another one that we often think about that reminds us how important it is and how valuable it is to spend time with our patients. And so Osler said that he who studies medicine without books sails in uncharted seas, but he who studies medicine without patients does not go to sea at all. And I think as we've learned over the last couple of days, and as we've seen in our own experience, our trainees, particularly our interns, have spent less time at sea over the last few years, especially with competing interests with work hour requirements and taking care of more patients in less time. And many of them are actually stuck in dry dock in an office in front of a computer. And Tim Neeson, who's here with us from Hopkins today, was involved in a time motion study on interns after the 2011 work hours requirements went into place. And we learned something that still astonishes me today, that our interns in our service spend only 12% of their time in direct patient care activities, only 12% of that time. And so we recognize this as an opportunity and a challenge to really reemphasize the value of that time with patients at the bedside. And two things happened in the last 18 months that have really allowed us to refocus some of our energies on a new clinical skills service at Hopkins that several of us who are here are involved in teaching. The first is that the iCompare trial began. I'm not sure if you guys are familiar with this, but this is a trial that's really designed to look at the effects and the impact of work hour regulations on residency training, patient care outcomes. And we were randomized, some people don't believe this, but we were randomized to the liberal work hours arm. So we're actually able to have interns do up to a 30-hour shift again. And as part of that, we recognize that we want them to spend more time of those shifts with patients. And so we decided to downsize our residency teaching services, our chief resident services, from 22 patients down to 18 patients, which meant that we had to create another internal medicine service to take care of those 16 to 18 patients who no longer would be taken care of by the firm system. And so that's when we decided to create this new clinical skills service, which has 4 interns, 2 junior residents, and is staffed by a hospitalist attending. And we decided through a clinical skills working group that we would make the focus of this new service clinical teaching and clinical reasoning and bedside physical diagnosis. And for a number of reasons, we chose to focus mostly on the cardiopulmonary exam in this year, partly because about 40% of what we see on the inpatient side is either cardiac or pulmonary or some combination, partly because there are some objective ways to measure clinical skills and objectively evaluate cardiovascular examination findings. And lastly, many of us were, I'm a pulmonologist by trade, many of us were cardiologists and pulmonologists. And so starting in July, we began this new service where we have 5 sessions a week with the interns on this service. And I'd briefly tell you what the sessions are. The first session is based on a physical examination maneuver. So either using a healthy volunteer or a patient in the hospital, we go over a specific cardiopulmonary exam technique. Takes about a half an hour to do that, and then each of the 4 interns practice. And then later that day, we take that technique to the bedside to an actual patient on the service and demonstrate how that technique is valuable and tells us something about the physiology of that patient. The next type of session we do is on physical, or diagnostic testing, and we've chosen to focus on echocardiography and chest radiography. And the echo sessions are not to teach the interns bedside ultrasound techniques. It's really to teach them that the echocardiogram provides information that enhances your physical examination and in many cases confirms that which you already know from talking to the patient and examining the patient. So we have the head of our echo lab who runs those sessions using echo images from patients on the service, and then we examine those patients together. The third type of session, we've actually purchased a cardiovascular curriculum that's available online that was developed by John Michael Criley, who trained at Hopkins and then was a cardiology professor at UCLA for many years. And this allows us to use real patient data, videos from patients that incorporate jugular venous pulsations, precordial impulses, auscultation findings, and then some physiologic data from catheterizations and echoes, and to really go through the physiology of disease and see how the physical examination helps us with that. And then finally, my favorite session, every Wednesday we invite a master clinician from the hospital to come and spend 30 minutes at the bedside with our interns. And this, selfishly, this is my favorite session because I just invite all the people who taught me in medical school who I know to be master clinicians. In the last month, we've had the head of rheumatology, the head of cardiology, the head of neurology, and these are just fantastic sessions. And little by little, we're starting to see attendings are coming to these sessions. They want to actually learn from these masters at the bedside. And so this has really allowed us to start building a culture where we want to instill that value of the bedside experience. And as part of that, I'm really interested to hear what everyone else is doing about evaluation. And so we have actually started to do both self-assessment surveys of our residents. So we looked at junior residents who had just finished intern year, and we looked at our residents our interns who were about to start, and we asked them some questions about their cardiopulmonary exam skills, what they thought was important about the exam, what they were confident in. And then we actually gave them an online assessment of some of those auditory, visual skills, and integrative skills. And what was really interesting is that our junior residents felt more confident on certain aspects of their cardiopulmonary exams. And then when we gave the interns and the junior residents the same exact assessment, there was absolutely no difference in their ability to perform certain maneuvers. And so I think that really reemphasizes that we have a challenge and an opportunity to go back to the bedside and really explore the value of that encounter. So.
Thank you.
Thank you, Brian. I think each institution probably has a corollary to Osler, and ours is Dr. Tinsley Harrison, who was the chief of medicine at UAB and went on to write a textbook bearing his name. And the story is told at UAB that when he was there in the 60s, he would gather his students at a bedside. The student would present the history, and then he would stop them. He would examine the patient himself, and at the end of his examination, he would actually tell the students what the test was that was ordered, what the result of that test was that was ordered, what the tests that were ordered that should not have been ordered, and ultimately the diagnosis. And so he was a master clinician in that way. And by the time I arrived at UAB in 2007, bedside teaching that was so strong had really faltered, and I was several of different islands of teaching that would talk about bedside teaching but would not do it in a systematic and structured fashion. And so as I would start each ward month, or 2 weeks as the case may be, I would orient the residents and tell them that today we have a grace day, our first day, but starting tomorrow we'll actually be rounding at the bedside and talking to patients. Now, to be sure, I did not emulate Dr. Harrison insofar as predicting the labs and predicting the diagnoses, but that was not a common process that happened in 2007. However, over the last few years, we've started to see more and more of a culture build of bedside medicine at UAB. And last year, we were pleased with the progress that we'd made in terms of talking about bedside medicine and thought we would evaluate ourselves and see how we're doing. So the chief resident, one of the chief medical residents and I got together, and we did a survey, and we asked several different questions of both our faculty and our residents. And one question asked from the perspective of the faculty was, faculty, regularly demonstrate physical exam findings on rounds. And with over 75 faculty who attend on wards responding, 65% said, yes, this is something that I do. But you may see where this is going, because we also asked the residents the very same question from their perspective. And the question was, my attending regularly demonstrates physical exam findings on rounds. And we would have been pleased to have 50%, but in fact, only 27% of the residents agreed or strongly agreed that their attending was demonstrating physical exam findings. So the question that came up for us is, why is what we think we're doing not being translated over? So we started Bedside Medicine 1.0. Now, that's not the term that we used, but as it developed, we realized that our first iteration was not as effective as it would be. We started with a morning report, very similar to what Errol spoke about yesterday, but the key difference was that we didn't have actual patients there. We had master clinicians coming in, talking about several things once a month, and the residents would then take that back to wards and hopefully implement some of those findings. And then we did another project, which I wouldn't have called it this until last night's session, but it was essentially a flip model of medical education where the residents were taking the physical exam findings to the attendings. We had a scavenger hunt, 121 items drawn from Dr. McGee's book that we could see on rounds, and when the resident identified those, they would take them to an attending who would validate it, and then the most people who found it at the end of the session, or sorry, the end of the year, would win a prize. Well, our flip ended up being a flop because we had very little engagement. And we think there's three reasons for that. One is that the residents may not have recognized what was looking at them. Two, attendings like myself may not have known some of the more esoteric signs when the residents came to us with those. And three, implementing that by tracking it on a medical records, not medical records, but a computerized system was not effective. So this past year, we've essentially instituted Bedside Medicine 2.0. And what we're doing is we're doing the morning report. We're now coupling that with the same master clinician teaching the clinicians, teaching those of us who are on wards, very similar to what we talked about here, how to teach their residents. And our hope is that at the end of this, we'll start to see everyone improving. And I think the last vignette I'd like to share is that there is some evidence that it's working. Just past month, I started my block of ward attending again, and I caught the very end of the month where residents were there, and I did my same thing. Today is a grace day, and tomorrow we'll start at the bedside. And my senior resident said, Dr. Russell, we're way ahead of you. We've been doing this all month long.
Let me just also say that there are several people in the audience that I know are also involved in similar efforts, and so we'll be asking you to speak, especially I know Dr. Ahmed in Rochester has done some really interesting stuff, so when we're done with this, I'm actually going to go to Dr. Ahmed and just giving him some time to marshal his thoughts. Andy.
Well, thanks, Abram. I've probably said enough about the kind of idea of culture and cultural differences between us, because, as I hope Junaid and I made clear, it is the existence of the exam, that exam we showed you a little bit, that drives all postgraduate teaching and learning. All trainers are not examiners, but they want their trainees to pass PACEs, so they take an interest in bedside clinical skills teaching and assessment because of that. So, you know, some of you may feel I'm overstating it, but I do strongly feel that just because that exam's still there, the culture has followed. Ultimately, it seems to me that however you choose to do it, teaching bedside skills or clinical skills is dependent on having somebody demonstrate things to you, then observing directly the learner doing it, and using a real patient at postgraduate level. There's no doubt at all that at postgraduate level, it should be about what their technique delivers. Do they find the signs that are there or not? For undergraduates, fine, you can focus on method. But I'm saying that really because I wanted to pick up on your survey, because one of the things that I've been doing when I'm here in Stanford this time is writing up a study that I started when I was here in Stanford last time. And we've surveyed almost 4,000 people around the world, not in the USA, but we've asked them just that question as well. Are you, as a trainee, actually observed at the bedside? And lots of trainees say, well, no, I'm not. Well, all the trainers say they're observing. And we also ask them, are people demonstrating things to you? And all the trainers say, well, yeah, we are. And the trainees say that not enough people are demonstrating. So even in our culture, it looks like there may be a shift developing where there's less demonstration and less observation. So we too want to try and find ways to improve that.
Thank you. I think Maya's been struggling with me to try and develop an outpatient sort of module, and I think one of the things that she can speak well about is the things that make it difficult in a busy outpatient setting to implement bedside teaching. So
yeah, absolutely. So I'm a primary care physician and general internist at Stanford, and I'm very interested in taking the physical exam to the outpatient setting, and was fortunate enough to join the Stanford 25 group 2 years ago. And teaching the physical exam in the outpatient setting comes with its own set of challenges. So we never know what kind of patient walks through the door. People can have amazing physical exam findings or can have no physical exam findings. Also, I cannot take my residents on bedside rounds because once the patients are done with their appointment, they leave the clinic. Another big challenge in teaching in the outpatient setting is our time constraint. Appointments are very short, patients have a lot of issues on their mind, and the physical exam often just falls away. It happens rarely that the attendings actually go into the room with the resident and watch the resident perform the physical exam. It's more likely that the resident does the physical exam, does the history and physical, and then comes out, presents to the attending. The attending has to trust whatever the resident found, and then they come up with a plan together. I believe, though, if you don't teach physical exam skills in the outpatient setting, you're really losing the residents because it's really fun. There are few things more rewarding in internal medicine than examining a patient, and then based on the exam, you can come up with a diagnosis, and you can tell the patient, this is what's wrong with you. And if you do a thorough physical exam, you can also potentially save the patient from getting expensive and invasive tests. So how do we teach the physical exam in the outpatient setting? And again, time constraint is a big problem, and that you never know who's walking through the door. You could do a perfect shoulder exam, but unfortunately that day you don't have a patient who has shoulder pain. So this is where I rely on the 5-minute bedside moment, or 5M square. It's really useful to just have a repertoire of a few techniques that you can teach in a limited amount of time, and you can even teach on a healthy patient. And the residents are so grateful when you teach them this. In addition to that, we also started teaching the residents prior to clinic certain physical exam skills. We started with the approach to the painful shoulder. Our next session will be on the approach to the patient who comes in with vertigo or dizziness. And the residents come in before their clinic, and they really appreciate that. And I believe if you show the residents how fun and rewarding it is to do the physical exam, to really examine their patient in the outpatient setting, they will start doing that. And then they're also more likely to pick up any pathological signs that the patient didn't complain about. I had a resident diagnose a melanoma just by looking at the patient. And that's just really rewarding.
All right, thank you. Well, I work at the Seattle VA Hospital, which is a special, very special group of patients to take care of. We don't probably have some of the organized efforts that others have mentioned, but we really have worked to creating this bedside culture at our hospital. Some of the things we've done is at least 50% of the attendings of the house staff teams at our hospital are young hospitalists. Many of them went straight from their residency to this attending level position without fellowships. And one thing that we're trying to change is really making sure that all of the presentations to the attending actually occur physically at the bedside of a patient. And one of the things that we try and do is just present in an organized way what the data is from the learner's perspective, from the patient's perspective, bedside presentations versus out in the hall or conference room presentations. And this is what the data shows. Some of it actually is from the Osler service at Hopkins. The data shows this. Number one, it's faster. Number two, unlike what most people perceive, patients overall, 95% of the time, love it. It's calming to patients, principally because they all of a sudden realize that their doctors really do understand what their experience has been, and that part is very clear. Learners love it in general, just because of the bedside teaching, the chance to see others modeling bedside skills. And then, of course, you can do the bedside teaching. So we really do encourage people to go to the bedside, not in the hall. This is ICU, this is wards, this is everywhere. It's not 100% are doing it, but that's what we try and do. And as part of that, we hand out a quick crib sheet of what the bedside presentation should be. This is a very short presentation that really would just include the chief complaint, which in that first sentence, there's no surprises. After that first sentence has to have the whole package. 72-year-old man with diabetes, hypertension, who presents with 3 weeks of dyspnea and a new left pleural effusion. And that's, there's no surprises there. We didn't leave out a chronic illness. We didn't leave out what their chief complaint was. We didn't leave out what the main focus of the admission is. Then the HPI, several sentences, rhythm of the illness, goes straight to physical exam. What are the key findings only? Vital signs, key findings, nothing else. Key labs only. And then principally, what do they think is going on? What are their plans? What questions do they still have? And what we've discovered, we work with a veterans group, and they are a special group of folks, but they really do enjoy participating in the educational mission. And so it seems to work out, makes it faster, people learn more. So that's one thing we do. The other thing we do is in our student rounds or our residence report, it does depend on who's leading report, but one thing we do is, often the way it is structured is it's a mystery case to everyone except the presenter. A single case might be presented. And we stop everyone at the end of the history and have everyone in the audience commit themselves to what they think is going on. Then we ask for the physical exam. And at that point, again, they have to comment, has their assessment changed or not? Are there additional physical findings they would want? And then what labs would they want, and what's the final diagnosis, and some teaching about it. So anyway, we really try and mimic the clinical reasoning exercise. Commit yourself after the history, and as you all know, that's where 90% of the diagnoses come from, as much as I love physical exam. But really, how does physical exam finesse the hypotheses that you've generated? We do bedside teaching rounds at all levels, students, so organized rounds. This is where we're not really the attending taking care of the patient, just the interesting findings. With students alone, we do with the chief residents who teach the residents, and then actually we have separate rounds for these young hospitalists who really are eager and passionate about the bedside exam, but really want some help on how to teach. And for us, the bedside includes not just our physical findings, but blood smears, gram stains, urines, and so we really get them used to looking at that data carefully on their own. And then finally, at our hospital, we have a very active postmortem program. As it turns out, 45% of the patients who die in our hospital have postmortem exams. And so that's a regular rounds for us on Fridays, and it's probably the most popular exam or conference in our hospital, because this is what it really creates humility in the entire group. I mean, we're sort of really upset if we go to the bedside and we hear that, well, we say, this is aortic stenosis, and the echo shows it's mitral regurg. I mean, that's a little bit humbling. But what about the radiologist who goes down there and presents the tumor in the liver that clinically has been diagnosed hepatoma, and it's not there post-mortem? I mean, it really, clinical imaging has sort of taken over the diagnostic standard on how we classify folks in the bedside, and there's no check on what they show. And it's very humbling to go down there and see that pulmonary embolus was an angiosarcoma, or that the tumor that we're treating is not there. So that's another key element, I think, that makes us all very humble about our interactions with patients.
Bilal, I'm going to have you come up here, if you don't mind, and we're going to leave half an hour at the end for questions, so you have about 2 minutes, a little more.
Thank you for giving me the chance. This is like For a heroin junkie, this is being in a conference full of people who believe in the physical examination. That's kind of what I'm feeling. I mean, I have to say, I thank you for sharing your experience. It is very hard to build a bedside medicine experience in any place, I would say. And I think in that slide that you see up there, community is the key word. So you have to build a community of people who believe in what you're trying to say. And the problems that we've had is to, number one, is to find that cohort of people who believe in teaching by the bedside. That was the number one issue that we've had. But we eventually found a group of people. We actually had to do a lot of exercises and workshops in which these people were taught how to train. There was a significant amount of recalcitrance of people not feeling sure they were good enough to teach by the bedside, so we had to get over that first. So what we do now is, it's kind of interesting, it's a little different to what everybody else is doing, is we do rounds, they're called Holmes rounds from Sherlock Holmes, and the whole emphasis is on observation. So I ask them to observe before they do anything else. And we have actually linked that with a local art museum in which we have them bring in paintings and have the students kind of look at the paintings and describe what they see, just describe what you see in the painting and then take them to the patient's bedside. What we also do is we have a psychologist and some students from the anthropology department at the university follow us as we do these rounds. So what they do is as we are interviewing patients, they actually are looking at us, and at the end of this experience, they pick a few of us, and they sit down with us and give us a narrative. We have developed a 27-point scoring system as to how we interact with the patient. So that's what I was pointing out this morning, standing at the foot end of the bed, how you interact with the patient, how you introduce yourself, the eye contact and all that. That's all observed, and the feedback is given right at that point. So how do you make the administration believe in what you're trying to do? So it's interesting. We at our place we have 2 hospital sites, and thankfully we have the luxury that some students and residents are only exposed to one site compared to the other site for 6 months before they start mingling with each other. So we have a blinded study here. And what we found was that I tell people it's like if you are going to a library trying to look for a book without an indexing system. That's what we're doing with the patients. So we are trying to cast a wide net by doing all these tests and trying to see if we can come up with a diagnosis. There really is no indexing system in our mind. That's what we do if we don't do the physical examination and history by the bedside before we embark on that journey. And what we found was that people who've been through this exercise, their testing cost is about 30% less compared to people who have not been through the exercise. So there's a less of a tendency to ask for an MRI scan or a CT scan or a D-dimer or a BNP right at the outset before you even start talking to a patient. So that's been so powerful for our administrators, because that's millions of dollars. Multiply that over time, over years, and they say, what can we do to help you to expand this thing? So I think that's been great for us.
Thank you so much. I should introduce Bilal. You can stay up there, please. Bilal is a member of the Royal College of Physicians, took his exams many years before moving to Rochester, where he's been for some years. We had the pleasure of having him here for grand rounds, and it's great to see you again. We were actually intimidated by the number of superb clinicians whose names we recognized coming to this conference, but we reassured ourselves that it wasn't about our teaching them as much as it was about building community. So we're really pleased that you're here. Before we turn it over into questions, is there anyone else who wants to share their building experiences at their institution? Don't all speak at once. Yes, Highland Hospital, Alameda, right? Okay.
So we're very different, I think, from the institutions that most of the panelists come from, in that we're a very small community teaching hospital with a sort of titular university affiliation. But a couple of years ago, we decided that we wanted to start emphasizing clinical skills more in our resident education program, in part inspired by other work that's been done, particularly at Stanford. And since then, we've been doing our best, with some help from Dr. Verghese and from Dr. Elder especially, to develop a curriculum and evidence-based physical examination that all of our residents have to go through. So we have a block schedule, which means that we have an academic half day, and our program director has been good enough to give us dedicated time in that academic half day, where we have a group of mainly young faculty go to the bedside to see real patients with our trainees to develop their clinical skills.
Thank you. Thank you so much for sharing. Over here, microphone. Up front, third row. Thank you, bro.
The reason why I hesitate to raise my hand, because I didn't actually do anything with physical exam, but something similar with ultrasonography at Denver Health Hospital. Of late, in the last few months, we have been, the effort is solely with myself and my group, without any protected time. We would round in the morning with the residents, specifically looking at the on-call team, and tell them, pick one patient today. We can ultrasound with you, and we're going to try to come up together using the physical exam and using the image on the ultrasound what the next step would be. People, I think the residents are much more excited about ultrasonography because it's a new toy they get to play with. But my fear with that, and as a director of ultrasound at Denver Health, I love ultrasonography, but I worry that we're going to lose our touch with the physical exam portion of it. So there's this elegant art, I think, that needs to be developed with integrating ultrasound and physical exam, or any other technology with physical exam. And I think having the residents being exposed to both of them at the same time is going to be quintessential to developing their skills.
Great. I think, yes. Microphone back there.
I wanted to mention that at Wake Forest, we actually applied for a Macy grant a couple of years ago, really to focus on professionalism and teaching professionalism at the bedside. This was led by one of our former program directors. And one of the things that we did that I think was very helpful in terms of promoting our culture was having faculty workshops and really understanding what the barriers were to going to the bedside. And we found that faculty had a lot of fear about what they might go into on a bedside presentation of a new patient to the hospital. A lot of discomfort for the patient and family that have been up all night in the emergency department and actually walking into that scenario. So one of the neat things that we did toward the end of these workshops was actually a simulation exercise with residents playing the part of the patient who'd been up all night, the family member who's frustrated because they haven't been told what's going on, and actually helping that faculty member with coaching to figure out how you would handle those situations. So for us, I think the next step in this is actually to promote more teaching of physical exam at bedside, but just focusing on getting faculty used to going to the bedside was the number one thing that we tackled.
Any other experiences to share? Yes.
I've been doing something.
Actually, one second. It's behind you.
So I'm from Canada, and we started something very similar to what you're doing, formal bedside teaching rounds that are happening on a weekly basis, every Thursday for the junior resident and every Friday for the senior resident. We have come across similar barriers in terms of faculty sometimes feeling unprepared to go to the bedside, or having some maybe feeling inadequate with some of their skills. And I was wondering if some of you have taught or are starting to think about developing a faculty development day locally at your institution to help the physicians and the teacher learning how to be an effective bedside teacher and how to improve on their clinical skills.
Maybe I can kick that off by saying that we've had the opportunity to teach several of our faculty in a particular context. You might have heard last night on the Educators for Care program, where every medical student is matched with one faculty member who follows them through their whole course. And since those faculty members are also will be in the physical diagnosis course, teaching them during the first year, second year, some of them are ophthalmologists, some of them are folks who don't do the physical exam the way an internist might. And so we had the opportunity to train them. And I think one of the things that we realized and they realized is they don't necessarily have to, overnight swallow Bates' textbook. That's not what it's about. It's really about modeling being with the patient. It's just presence. I think presence is so important. It's about, again, taking certain building blocks of things that they know. And especially if they see that in their course they're going to be going over neck veins as part of the curriculum, making sure that they're comfortable with it, because you lose a lot of credibility if you go to the bedside for a specific session and it turns out your skills are no better than the student who's never seen it before. So we've also done a fair amount of training in SGIM and certain other venues like that. And much of what you saw in the last 2 days is what we do, is emphasizing that you don't need to know it all, you just need to start building. Stephen.
Thank you. Last academic year, 14-15, we had a series of monthly faculty development sessions for those who attended on the wards. It was the third Tuesday and the third Friday of every month. Those who weren't able to make one would come to the other. And it was very well attended. And as part of the survey that I alluded to earlier, we also asked the faculty who attend, when was the last time you had formal physical exam training? And many of these faculty members actually taught the Introduction to Clinical Medicine course, and almost without fail, it was in medical school that their last formal training was, or for those who may have gone to SGIM. And so what we found is that, at least in our institution, there's a hunger among the faculty who are teaching to have some formalized skills. And so modeling what was done last year with the faculty development, our hope is to recapitulate that this year with taking 6 individual systems and then having the expert teacher teach 1 or 2 topics within that system during a similar Tuesday, Friday conference on a monthly basis.
There's a question in the front here. Yes.
I just had a comment. I mean, we have also started doing something similar in Dallas. I'm from Dallas VA, and we have started doing weekly bedside rounds, physical exam rounds for the third-year medical students, catching them young as it is, and then kind of training them. And they have been very well received, and we are kind of mirroring that at the UT Southwestern too. And actually, commenting on what he said about the bedside ultrasound, Jerry said here, we are actually using bedside ultrasound as an extension of the physical exam. Like, fine, if you think there is hepatomegaly, maybe you can look at it. Or if you think there is ascites, let's do the ultrasound and take a look at the fluid there. And so kind of using bedside ultrasound as point of care ultrasound and then kind of building it up from there and teaching them.
So, yes.
We preface a lot of these rounds by your TED Talks as well. We use them for the human touch. I think I've found a lot of what we're trying to do here is not to teach the technique, but also the approach to the patient and be compassionate and be empathic. I think those are very crucial points that we kind of miss when we talk about physical examination skills. I think that's a part and parcel of when we go and see a patient. So we use that a lot. We use the Stanford 25 a lot, but we've changed that a little bit by the perspective that we put in the Stanford 25 is how do you get to a diagnosis rather than how do you do the actual examination, which is a part and parcel of that. One thing which I kind of forgot to mention was because the younger generation is so much into technology that they are kind of saying, oh, come on, we don't need to do all these things. So we have tried to include technology in our teaching rounds. So wherever there's a patient now in a hospital, there's a computer screen. So we've tried to be inclusive of those screens. So we do the examination. So let's say there's a pleural effusion. Then we bring up the chest X-ray or the CT scan just to corroborate or just correct ourselves and show the patient those things as well. The patients, you wouldn't believe how interested they are to look at the visual image of what we see, and as we try and describe that in layman terms. So we've kind of included those in our teaching rounds as well. We've also included these visual images in end-of-life discussions. So I'm also a palliative care physician. So if we talk about end-of-life, we are actually showing them the scan, the whole discussion changes. You wouldn't believe how they start saying, all right, so this is what you meant by saying I had this metastasis in my brain, so this is what you meant. And now we also have the pathologist surrounding with us. If the patient agrees, she brings the photomicrographs, which we talk about, and the patient also sees those too. So there's opportunities for expanding the bedside rounds by being inclusive of the compassion as well as the technology, which I just want to kind of throw it out there.
So I want to change the discussion a little bit and ask the assembled folks and also you in the audience. There's a number of obstacles to our achieving this ideal of people examining patients well and not missing obvious stuff that leads to diagnostic errors. I think the biggest obstacle you alluded to is that residents spend 15% of their time actually with the patient. And Jeff Chi in the back of the room has a paper coming out in the Archives of Internal Medicine, or JAMA, what's it called now? JAMA? Yeah. Basically showing the same thing, that our residents are logged into the computer using it the moment they arrive, a little dip for morning report, and then a dip for lunch, and then back up till they leave. And it's actually not clear when they're actually seeing patients. So And again, as I said the other day, that's not their fault. I think they would like nothing more than to be seeing patients. This is our doing. We let this happen. So I want to ask the panel, how do we overcome the electronic medical record obstacle? And secondly, the other problem that we face are what I call system issues, where the hospital wants team care rounds at a certain time, the program director wants morning report at a certain time. It seems that the last thing on the priority is bedside rounds. So when your institution itself doesn't really value this except sort of in a nominal way, I mean, speaking metaphorically, not our institution, but generally, and when you find there are obstacles that have to do with process things that are important but not that important, how do you tackle that? I mean, maybe we'll start with Hopkins and then Alabama.
So I think the biggest thing that we've realized is we have to set the environment, particularly for the interns, where they're free of distractions as much as we possibly can. And so that really starts with buy-in from the junior residents. So on this particular service, when we recognize we don't have a lot of time to be with the interns, but for that half an hour every morning from 8:30 to 9, the junior residents on the service take the newest ASCOM phones, they forward their pages. So the interns, and then we take the interns away from the distractions. So if we're going to do something in a room with a faculty member where we're using a standardized patient, or we're going to do something that is not directly at the bedside, we are in a separate room with no computers other than the one that might project some slides, and we take them away from that distraction and try as much as we can to have them focused. And we found that 30 minutes, although it doesn't seem like a lot of time, seems to be the sweet spot where we can have them not looking at their watch, starting to fidget and reaching for their phones because they haven't been online and they're not worried about what's happening. The other advantage that we've had on this particular service is that this is an off-hours admitting service, and so they actually admit patients from 7 in the morning until 1 p.m., and their rounds don't happen until the afternoon. And so there's actually a little bit of a break in the morning before the admissions start coming in, where we have them sort of as a captive audience where they can focus on whatever it is that we're attending to that day.
We have done some stuff similar to what Dr. Ahmed has done in terms of embracing the technology. I thought this was unique to UAB, but it's not insofar as we have a COW, a computer on wheels, that we take around, and I've heard others use that same term here this week. And essentially, when we go into the room, we will all introduce ourselves, who I am, and residents and medical students, and we will actually designate one of the people on our team as the recorder or the person who's putting in orders and so forth, and they will be designated as such so that the patients aren't distracted by somebody who's pecking away on the computer while we're trying to do other things. So we've tried to do a little bit of a fusion from that standpoint, and it seems to be fairly well received and helps from an efficiency standpoint as well.
So just a general point, I think that if we're thinking about how we can get physical exam, get bedside assessment really going again, I think there's potentially 3 routes in, and I spoke about this at Stanford Grand Rounds last week, amongst other things. The first is the doctor-patient relationship, the touch stuff, if I may call it that I think everybody regards as important. But unfortunately, I don't think that on its own is going to win the day. I think we've been, yourself very eloquently, Abram, and others over several years now have been making that case. And I don't think on its own it's going to get us back there. The second is diagnostic error. Quite rightly, there's an increasing interest in patient safety, in the contribution of poor physical exam to diagnostic error, and it may be that will give us some leverage. But I think the most important thing is environment, and what Bilal spoke about, and that is that we've got to start looking at the cost effectiveness of physical exam. Money talks and all these things, and if people could start to show that doctors who are more confident in their bedside skills, who have patients who are more confident in their doctors, if they do less tests, cost less in care, maybe that will be a useful way in. And I know Paul Bergel's in the audience. He may not want to talk about it, but he's just published what I would regard as a very important paper, just starting to ask that question. How do we start to look at the cost effectiveness of physical exam in the way that Bilal suggested?
Paul, are you here? Yes. You want to talk about that?
I'm back here.
Can you get a mic before?
Thanks a lot for the shout out, Andy. Yeah, that's sort of the angle I'm taking. I'm obviously very new in this game. I'm in my second year of being a junior faculty member, and that's one of the big angles. I think it sort of it goes nicely with the diagnostic error, and that's sort of where a lot of this thought process came from. But looking at Dr. McGee's book, let's pick the things that are really most cost effective in limiting follow-up diagnostic cascades. So that's actually something I'm working on. If any of you are interested in participating, I've been interviewing people around the country about what are the physical exam skills that we can really use to limit that diagnostic testing and really have an impact on our cost of care. I think the quintessential example is the echocardiogram for the murmur that many of us can identify as an innocent systolic murmur, but I think that's one of the big hooks for the young learner. I think a lot of people are interested in this cost of care issue, and if you can hook them in and think about that, that's, I think, a huge way to rope in the millennials.
I think we'd love to sort of encourage that kind of collaboration. I should mention, parenthetically, in your bags you had a paper that is in press on the consequences of oversights in the physical exam. And we simply collected anecdotes and we sent the surveys out to as many people as we knew, told them to send it on to other people, trying to just get a sense of the sort of epidemiology or the shape of stories of oversights. And you won't be surprised to hear that the most common oversight was simply not doing the exam. Secondly was the recognition that the patient has a backside as well as a front side. And thirdly, that if you don't expose the patient, you're going to miss things that are in the places that you didn't expose. I mean, there's all sort of simple truisms, but I mentioned this only to say that we are talking with Andy about expanding the survey. So you might get from us a link to the survey shortly, asking you to contribute an anecdote of an oversight that resulted in consequences. Andy's contemplating sending the same survey or a modification of it to all the fellows of the Royal College of Physicians, 3 colleges, because I think that may be what it takes to change the course of the ship, is the public's recognition that this is dangerous. I know we have a lot of hands up, so I want to try and get to those. We have 10 minutes left, so let's, I don't know who I'm going to go starting at the front and work my way next to you and then over there. Yes.
I wanted to add one more point to the discussion as to why, as doctors, we end up spending just 15% of the time bedside. I think one major issue that pulls us away is the need for so much documentation. And I'm kind of beginning to think about the utility for that documentation, and I don't think that it necessarily serves the patient hugely. And I think a big reason is the fact that we want to be able to bill adequately. And I wonder if, as a society of physicians, we need to speak against that. There's one type of solution where we have augmetics to try to be a solution for the documentation. But I really wonder if we need, that level of detail in the patient record. And, sometimes when I look at the resident notes that, they do spend a lot of time at the computer, but it's really kind of cutting and pasting and moving them forward. But they end up doing that so there can be adequate billing. But sometimes what I get most from a note is if I would look at a, note from a GI consultant who is actually not billing for that visit, it may be just 5 lines. And I get, all the essence of what I need. So I wonder if, trying to find the technologic solutions of kind of translating the essence of the visit into a note versus also seeing, how much do we need to document? Because in the end, we end up spending a lot of time trying to extract, the relevant information from that note too.
That's very well said. Yes.
Yeah, I just had a question for the people on the panel. If any of you have had experiences with giving grand rounds at institutions where there isn't a strong culture of bedside teaching, and if so, if doing that has helped to sort of jumpstart an improvement at any of those institutions.
I can't say that I recall that. I'm sorry. I don't. The people who invite you often, as you can imagine, are very interested in the subject to begin with. I wanted to comment just one. How do you get faculty at the bedside when they don't feel competent? And And part of that's developing the clinical skills and the 5-minute moment and all the things that have been reviewed. But one thing I always show our young teachers is there are 4 photographs of Osler in Harvey Cushing's biography. They're classic photographs. It shows Osler at the bedside, and it shows him inspecting the chest of a patient, palpating it, listening to it, and then there's a 4th photograph. And they're titled Inspection, Palpation, Auscultation, and then the last one shows Osler at the bedside. He's looking like this, and he's kind of looking at the patient, and it's entitled Contemplation. And it's very clear he has no idea what's going on with that patient. And so I show them that, and I say the best of teachers sometimes had no clue. And it's what you do with that moment at the bedside with your learners. Which consultant are we going to ask? What tests are we going to do? It's okay to say you don't know, and be fearless about it. So I make sure they see those photographs.
So I Johns Hopkins at a medical school in Malaysia for about 3 years, and I had the privilege of helping to set up our clinical clerkships. I spent about a year there at Hospital Kuala Lumpur, which is one of the largest hospitals in Southeast Asia. And we were the only graduate medical program in the country. There's one in Singapore, but basically in the region other than in Singapore. And when we arrived at the hospital, we were assigned to a 30-bed ward. And medical students were seen but not heard from, and were essentially scribes, and some of them were not even allowed to write in the chart. And it took us about 6 months, but we were able to slowly demonstrate that our students actively participating with bedside rounds and actively participating by spending time with the patients and adding in key historical information added value to the actual day-to-day operations of rounds. So by the time we left, after about, I'd say 9 months on the wards, our medical students were allowed to present, whereas medical students from other schools were not. And so, it wasn't a grand rounds environment, but it took time. It took about 6 to 9 months for us to get buy-in and to prove that even at the medical student level, spending time with patients actually adds value to that interaction. Yes?
One of the things that I've observed with working with trainees is the alarming rates of burnout and disengagement and distraction when they're on the wards, despite decreased work hours requirements. And I'm wondering if there's just any way to kind of make the argument or the case at an institution for the sort of long-term career implications of this kind of burnout, less time at the bedside. Because for me personally, my job satisfaction and professional sort of happiness at work is highly dependent on how much time I personally spend at the bedside. And I just wonder if there's just another way to kind of get physician well-being on the table as part of the discussion for making a better argument for time at the bedside.
I will say that it's been a powerful argument here. The dean had commissioned a survey, the results of which were shocking, that there is a lot of job dissatisfaction. And I think it boils down to many things, but especially the sense of no control over the time you have to spend on the machine and not with the patient. And you hear patients obviously articulating the very same thing. I guess the trick is, how do you translate that, into something tangible that we can then change the system with? And certainly here it led to a big wellness committee, which is really, most committees, you wonder what they're going to do and what product will come out. This has been incredibly effective. It's broken into 4 wings, one of which is looking at research and publication. I have learned a lot. But again, I think it's that kind of discontent that has to fuel change when it comes.
We did a kind of a short survey monkey on that. Asked the resident students as to what makes them the happiest at the end of the day when they go home. So there were about 140 respondents to that. And I think 99% said on the day that they saw a patient with a master clinician who showed them what to do. So the Socratic method still lives on. And I think, as to your question, I think if you want to prevent burnout, I think this is the best way to do it.
One there, and then the gentleman with his hand up. I'd seen him from the start, yes.
Thanks very much. I'll shift back to a couple of things that we've covered already. I'm Mel Anderson. I'm the chief of hospital medicine at the Denver VA and one of the APDs for the residency program. And inherited a great med-bed culture. Things we've done to perpetuate that are coaching, peer coaching. So we have a system where we pair off with fellow faculty members over the course of the year and go on rounds with them and have a structured observation tool. Entirely formative. It really helps I think helps the observer as much as the person being observed. And then through our Academy of Medical Educators through the school, we offer bedside teaching workshops and essentially an educational consult system called iTeach, where you can very privately request one of the AME members to come, either watch you give a talk or precept an afternoon clinic or go on rounds. That's been, I think, helped sort of promulgate the MedBed culture. And then in response to the question earlier about whether a grand rounds can change things, I had the great good fortune of giving a grand rounds in a Southern California institution, but that then led to an invitation to come back as a visiting professor with a colleague of mine and go on rounds with them and do faculty development. Similarly, in a Midwestern place, we did the same thing, and I'll just share this quick anecdote. Before we gave our faculty development workshops, we went on rounds with them the very first morning to sort of assay the baseline state of things. And their structure was, I think, what a lot of folks say bedside rounds are, which were, as Dr. McGee points out, hallway rounds, and then a very brief, hurried, truncated bedside visit. And it was literally they were in the way of all the people pushing carts in the hallway. It was awful. And then the very last patient that we saw, we were discussing there in the hallway, and the patient joined us. The patient came out of his room, and I'm pretty sure he said, "They're out there. They're talking about me. I guess that's where the action is. I'll go out and join them." And I couldn't have planned it better to plant the seed for maybe we should change.
Tell us again where you're from. I think a lot of us would be interested in the iTeach concept.
The iTeach, the University of Colorado.
Okay, wonderful. So we have time for one last question. The gentleman in the white shirt there had his hand up for the longest time, and that unfortunately will be the last question because of time.
Hi, I'm a unique perspective. I was UK and US trained, but I work in Singapore now. I've worked in New Zealand. All of these continents face the same challenges and frustrations. So that resulted in me coming here with some kind of hope of getting some ideas. My interest, or part of the challenge that I faced as a consultant working here in the US and now working in Singapore, is one of human factors more than anything else. This is a wonderful idea. We all agree that it should change for the better, but at the point that you make the transition from a plan to action, I've faced, as I'm sure all of you have, barrier upon barrier that are behavior-based. So I guess this is more of a question than an answer. I know that from the aviation industry, we can get a tremendous amount of lessons learned. We don't necessarily need to reinvent the wheel. There's been a very successful culture change in the aviation industry towards safety and more practical propositions towards a much better industry. We're having a lot of frustrations mimicking that or implementing that in the medical industry. As an example, in Singapore, I work with a lot of registrars, MOs, residents who've passed the PACES, who've passed the MRCPs, or who are ABIM trained, but who would just say, there's an infiltrate, it's a pneumonia, and start antibiotics. And so something that I hope to take away from all the brain power here is how can we incorporate the human factors of behavior modification. How do we face that challenge in implementation of this very crucial concept? More questions than answers from me, actually.
Well, that's a very deep question. And in many ways, it's sort of a nice note to end on, because I think one of the things that we've been thinking about is that this dialogue has to continue. And I don't know what form that takes, maybe a society of bedside medicine or some iteration like that that's nothing to do with us, one institution, but rather all of us collectively coming together to start to articulate the principles of all these things that you said and that you've heard, to take us on a path of action, to change the things that we can change. But that's a larger discussion than we have. I want to thank our wonderful group of panelists, including an impromptu panelist.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.